This is silly. Alright. Hello everyone, my name is Maura Howard. I'm going to be talking to you guys about expedited partner therapy. So, an introduction. Chlamydia and gonorrhea are two of the most prevalent sexually transmitted diseases, and during 2014 and 2015, they increased. Treatment for these infections is extremely easy with a single dose of antibiotics, and it's extremely important because of the increased risk of the woman developing pelvic inflammatory disease and other reproductive problems. So, some background: expedited partner therapy is the practice that increases the amount of partners being treated for chlamydia and gonorrhea versus the standard partner referral method. Expedited partner therapy is recommended by the CDC for the treatment of chlamydia and gonorrhea, and it ensures that both sexual partners are being treated for the disease. Partner-delivered partner therapy is the most practiced and studied form of EPT, and is when the patient and their partner receive the antibiotic therapy. The purpose of this review is to provide information about the community health nurse's role and research evidence regarding expedited partner therapy use. So my method, I performed a literature review that was conducted to determine the best practices of the community health nurses regarding EPT. The question used to guide it is, what is the community health nurse's role in implementing EPT? Databases search for PubMed and PubMed Central. The search term used were expedited partner therapy, chlamydia and gonorrhea, and 6 articles were reviewed. The literature review I focused my literature review on 2 main parts, which was the efficacy of EPT and also barriers regarding EPT. So, some studies that showed the efficacy. There was a 4-month, at 4 months checkup, 12% of the patients who did patient-delivered partner therapy had repeat infections versus 14.9% of the standard partner referral group. Another study showed that 10% of the EPT group and 13% had recurrent infections with the standard patient referral group. There was also a study that focused on a 3-year public health intervention of EPT. This decreased chlamydia rates from 8.2 to 6.5 and decreased gonorrhea from 59.6 to 26.4 per 100,000. So some of the barriers that I'll highlight throughout the PowerPoint is mismorbidities, legal issues, adverse effects of antimicrobial therapy. There's concerns about statutory rape and intimate partner violence that are barriers when implementing EPT. So mismorbidities, healthcare providers see it as a missed opportunity to assess patients, especially those men who have sex with men and female partners, because men who have sex with men have increased risk for HIV, and female have increased risk for PID and other reproductive problems. So they see that this is an important thing to have them be assessed, but the CDC still recommends that expedited partner therapy is used because it does increase the female partners being treated for their chlamydia and gonorrhea infections. So some of the legal statuses, like I said, the CDC supports EPT. It is permissible in 38 states. It is allowable, potentially allowable in 8 states, and it is prohibited in 4 states. 35 identified states feature 1 or more laws that permit or may facilitate healthcare providers to use expedited partner therapy in practice. So prescription writing is a big barrier that healthcare providers face because 11 states prohibit pharmacists from dispensing medications to those who have not had a physical examination, failed to establish a physician-patient relationship, and those who are not the definitive pursuant of the authorized prescription. And 35 states require some patient identifying information on the prescription. So the conclusion of that is that there needs to be state and institutional guidelines so healthcare providers are clear on what they can and cannot do. Some of the identified institutions are the Center for Disease Control and Prevention, the American Academy of Family Physicians, the American College of Obstetricians and Gynecologists, the Society for Adolescent Medicine, and the American Bar Association. So another identified barrier is adverse effects. The risk of serious adverse intolerance, toxicity, or allergic reaction is low for the regimens recommended for the treatment of both sexually transmitted diseases. There was a study that during the 3 years public health intervention, there was no reported episodes of anaphylaxis or major drug reactions. So more about the statutory rape and IBP concerns. So expedited partner therapy might require exposing the partner's name and age, which may trigger reporting a case of statutory rape, depending on the state. And this is a barrier for the patient because they don't want to go get treated for their sexually transmitted disease if they're going to get in trouble with statutory rape. IBP, expedited partner therapy, is recommended only after the obstetrician, gynecologist, or other providers has assessed the risk of intimate partner violence associated with partner notification. And ACOG and the Society for Adolescent Medicine stated that they should not implement EPT if there's suspected child abuse, sexual assault, or any other situation and the patient's safety may be compromised. So to conclude, the evidence says that EPT reduces reinfection rates and increases the amount of people being treated for chlamydia and gonorrhea. The CDC and other professional organizations support the practice of EPT. However, there's obvious barriers that still remain. To overcome these barriers, there needs to be clear guidelines from state and institutional policies. So my recommendations for the community health nurse, you have to identify barriers within the community. You have to be aware of the legal environment and institutional guidelines surrounding EPT. You have to assess the patient's health, lifestyle choices, and lifestyle perspectives. You have to assess the risk for intimate partner violence and statutory rape. You have to assess the patient's understanding of antimicrobial therapy regimen, adverse effects, and safe sex practices, and express the importance for female partners to seek treatment for STDs because of their increased risk for PID and reproductive problems. So for the community health nurse, it's extremely important for education because you're educating both the patient and their partner. So you have to really assess the patient's understanding of the partner therapy, the adverse effects, safe sex practices, and everything, because it's important for both the patient and the partner to have that knowledge. Those are my references. Any questions?